Well, thank you very much for the introduction. Let me just get my slides working. Well, I took up microwave. Actually, I learned it from Professor Whiteley, actually. I went to London to see him do HIFU. And in fact, I looked at the microwave and I found that much more appealing at the time, actually. So I want to thank Mark for that. And I want to thank ECO also for giving me this opportunity to give my experience using the microwave, which is now quite, over the last couple of years, I've done nearly 150 of these. And I must say the results are very good. And I'm going to, first of all, give you a lowdown of what I have done and what the VenaSeal is like in Singapore. And then I'm going to go and talk about our results from the MAESTRO study, of which we did a prospective registry and collected data and outcome data, which I'm going to present first time at this meeting. I work at Singapore General Hospital, although I've recently about to leave and to go fully private at the Vascular Endovascular Clinic, where I'm going to continue to do this procedure for our private patients in Singapore. These are my disclosures relevant to this talk. So just to give you an introduction, should we be doing endovenous ablation? Well, yes, I think the SVS and AVF guidelines give a 1B recommendation for endothermal ablation. NICE guidelines basically says you do endothermal before foam, before open surgery. Otherwise, you do conservative and you go stockings. All of this data is based on efficacy, safety, and quality of life data. Basically, a closed, ablated superficial vein, no matter how it's done, is probably good in the long term, however it's accomplished. There is no kind of guidelines as yet for non-thermal, non-tumescent data, and that is still yet to be defined. So these are the endovenous ablation categories. We've got thermal ablation from laser, radiofrequency ablation, steam, and microwave. I've used all 4 techniques, and I must say I've actually now really kind of denigrated over to microwave completely. Steam was what I used in the UK a little bit, but to be honest with you, I think that's probably for being phased out. In terms of non-thermal, non-tumescent techniques, I have a big experience using mechanical chemical ablation and cyanoacrylate glue. I must say they do work in our population of patients, in a lot of patients, but not every one of them will benefit from that. As I said, NICE guidelines currently do not give a formal recommendation on using this. The data is still very much in its mid-infancy, and we don't have any long-term data, to be honest, past 5 years on these techniques. So radiofrequency ablation, this paper from the host and his team, unique 15-year-old data now in a number of about 58 patients. 88% clinical success rate at 15 years, 100% satisfaction rate, and basically the re-interventions are low. Basically, you're re-intervening for de novo or new progression of disease. So why actually do you need this? This study is basically, again, from Worcester, from Dr. Naimiki's group, looking at different uses of types of radiofrequency ablation in about 180 patients. And shows the problem is there were some early failure rates, which we have seen, and I've seen a second opinions on quite a number of patients with EVRF and VenaFit. And they've even suggested that we be starting the ablation at 5 millimeters from the saphenofemoral junction. In my opinion, the radiofrequency ablation basically are heating rods. They do not equate to actually causing transmural cell death, is what you want to give you a permanent solution. So this is where, in terms of RFA, I think this obviously it's a pullback mechanism. This is the VenaFit device from Medtronic. And what it does is that you need to basically get good application of the catheter against the cell wall. You've got to empty the vein of blood. So you basically need to put the head down, but you need good contact. It does cause problems with pain. And even in laser, this is compared to laser, it does cause can cause similar amounts of pain, although less in our Asian population, and can cause quite a lot of bruising, and nerve damage is not unheard of. Post-operatively, a lot of these patients need compression, I think very much for symptomatic relief, as well as reducing the edema that you get, especially after phlebectomies. So the question was, do we need another thermal modality? And I brought this up a couple of years back. In terms of what we treat in Singapore, this was a survey of vascular specialists across the country in both the restructured as well as the private hospitals. As you can see from this, what it shows is that there is a varied practice. RFA and laser seem to be, in terms of endovenous procedures, the most common, but glue has been actually on the increase in the last couple of years. And as you can see, how clinicians define on what to treat and what influences their treatment options is very much the clinical pattern of venous disease and the presentation and the degree where the venous reflux is. We did a comparative study between Singapore General Hospital and Kathleen Gibson group in Bellevue in the US to look at Caucasians versus Asians. We took 200 patients, and what we found was that Asians tend to present with higher SEEP scores, and those with total GSV and concomitant SSV reflux compared to Caucasians. And at diameters all down the leg, from groin down to the ankle, the diameters were larger than our Asian counterparts. And this is the kind of CVI spectrum we tend to get, very late presentation with pigmentation. So the skin isn't great. That is why things like glue has really taken to the forefront in Singapore. You go through a difficult field and potentially through just one incision or one needle prick. The problem with these using foreign bodies is that you get this phlebitic reaction, or what we call the VenaSeal red reaction, which is what I've called it. And you can get it in any patient. You can't predict generally. The data suggests you cannot predict what types of patients get it, although there's a preponderance in those who are females. And the fact is you can get this so severe that you can get a rejection of the glue, and then you have to excise the whole tract, which is even worse. And you can see some of the glue coming out of the puncture site. Also, what we've noticed from our data from ASVS is that there's a cord pull. When the vein gets blocked off with glue, you get a cord pulling, which can last at least about 12 months. So what's the principles of microwave? As Mark actually alluded to, it goes to a temperature of about 85 degrees, so less than laser, less than RFA. And basically what happens is that it causes a coagulation of the blood, heats the water, and basically get transmural cell death. Which veins do I choose for EMA? I choose veins that are C2 and C3, big truncal veins, big diameters, which I don't think are suitable for non-thermal, non-tumescent techniques. These are the ones I really pick because I think these are the ones that do the best in terms of outcome. The setup is what I do normally. The patient, if they're going to have phlebectomies, are generally done under a general anesthetic. If they're done with no phlebectomies, I will do this under sedation and local anesthetic. Generally, our vein in Asia, the great saphenous vein goes much more posterior than our Caucasian counterparts. So I hook them underneath a little bed, basically rolled up bed, to actually bring the vein closer anteriorly, basically to the surface. So it's easier to puncture and basically put your tumescence in. I will basically get the needle. I will puncture the vein generally at the distal end of where the reflux is. And I think the beauty of microwave is that you can go lower than the proximal calf, especially at the protocol that I use. And in fact, you can take it right down to the ankle, although you've got to be a bit more careful there. But I have not had any kind of nerve injuries or permanent nerve injuries with this procedure. As you can see, I do a micropuncture technique, and then I put in a 6 French sheath generally to basically get started. Again, just at the lower point of the reflux, you place the sheath, you mark the great saphenous vein, and basically you get access this way. And then you put the antennae, and I normally leave it about 2 centimeters below the saphenofemoral junction. It basically is quite a floppy catheter. So for those which are very tortuous veins, you may need more than one puncture technique, and because there is no inner lumen to allow you to use a guiding wire to get up to the junction. And this is the setup with the ecosystem, along with the tumescence, as well as the pump that I use. And I do not connect the wire or the thing up directly first. I use it to gauge, to get up to the junction before I start connecting any of the wires to the machine. Normally, I would place the catheter, it's very obvious on ultrasound, just below the epigastric vein to allow any outflow of the vein, prevent any kind of reduced risk of DVT. But generally, I place it 2 centimeters below the junction. I think that's the pro positioning is important, and then basically you fix it. And then I will give a tumescent, when this is my cocktail that I've used over the last 10 years. I've not changed very much. I use both lignocaine, a bit of adrenaline to reduce the bleeding, the bruising, and a bit of sodium bicarbonate as well. And basically gives anesthesia, a thermal barrier, and allows basically the heat transfer. So, and down basically around the ankle or around the distal calf, I'm a bit more careful with this and making sure that there's good amount of tumescence given. And basically want to basically compress the vein around the probe. Basically, when you infiltrate the solution, this is what I do. I both do a longitudinal technique and a transverse technique, depending on how the patient is anesthetized. I can use a long spinal needle from Bard or the short one. And theoretically, you can actually do this in 2 or 3 injections if you're doing this in the longitudinal plane to push basically the tumescence up the plane. And actually, I've noticed over the last maybe 50, 60 cases I've done, you don't need as much tumescence as you would with laser or with RFA. So long that you get a good halo effect around the thing, you can actually minimize risk of heat-induced damage. You confirm the final position of the antennae before you start. The only thing you do is put the head down to just reduce the vein of blood, but you don't even need to compress the vein at all. And these are the markings on the catheter to show you. Basically, as I can see from my mouse, the tip, this is the 3 dots that's your last amount that you would take out to do the heat transfer before you remove the catheter, and you pull back every 1 centimeter. And these 3 dots here is the 15 centimeter gauge mark where you've got to remove the sheath, otherwise you're going to heat the sheath up. And it's just a pullback mechanism, and that's probably the most thing that you're going to be waiting for before the end. And that can be pretty much, you've got to do this correctly so that you make sure that the vein gets heated and coagulates and fibroses down. You basically pull back using a technique, and I'll show you what I use in terms of the protocol, which is actually different from what has been published in the literature so far. You don't need to compress to get any apposition of the vein, which is the real ideal situation, especially if the patient is awake and you don't want to cause minimal amount of pain. And this is the protocol. I call it the Whiteley protocol because actually I learned this from Mark, actually, although it's never been published as yet. I use a 40-watt setting at 7 centimeters per centimeter treated. The proximal 5 centimeters I will treat twice, very similar to RFA, but you've got to make sure that the vein fibroses down. If the vein is greater than 10 millimeters, I will basically increase that to 9 seconds per centimeter, and I will watch for the vein to contract, as I said, for the first 2 or 3 centimeters. Otherwise, I'll give 3 cycles. If the vein is very close to the surface, it's important to push the vein off the surface, and potentially you may have to drop the wattage as well. And that's all you're left with at the end with a puncture site. And then I do my phlebitis in the normal way. I will give the patient 48 hours of a compression dressing, which I'll do myself. In some instances, when I've not done too much phlebectomies, patients actually generally don't wear the compression, I've noticed, and actually give them the option of wearing a stocking. And there's no evidence to suggest whether a stocking really does help in the immediate aftermath after thermal ablation. And that's my post-procedural care. I give Daflon now for 2 weeks post-op because there's some evidence to suggest that vena constrictor actually improves their symptoms. Generally, if they're going to wear a stocking, I would say about 5 days, especially in the temperate climate. And most of these patients resume normal activities within the 3 or 4 days. But I actually ask them to do no strenuous or aerobic activity for 1 week before actually coming back to see me. And those are the duplex scans. You can see that very much, you can see almost thrombosed immediately post-op at the junction. And you see this very clearly on the ultrasound. And this is one of the results of a lady I did with probably a very big thigh. You can see this is actually 2 weeks down, well, 1 week down the line, actually. And you can see with a very big vein that she had, I think it was more than 10 millimeters, you get a very good result cosmetically as well as symptomatically. Another around the thinner thigh, again, showing that the vein had been blocked off successfully at 1 week with minimal bruising in the thigh region. This is another lady, which I did with MSA. You can see the MSA has caused more bruising than the actual microwave procedure in the thigh region. And sometimes you don't see the clot off, but it's completely non-compressible on ultrasound, and there's no flow. So the initial EMA experience at SGH, what we've found generally is that there's less post-op pain, bruising, and swelling. Patients tend not to use any post-op compression hosiery, especially in our temperate climate. And some of the even bigger great saphenous veins we've done, it's been very effective. And like I said, you do not need to collapse the vein onto the catheter. For ulcers, we've used it for ulcers. You can see the catheter is taken all the way down to the ulcer bed. And I've reversed it the other way to go retrograde into the ulcer bed as well, without any problems causing nerve issues around the great saphenous vein or using the saphenous nerve. Even in small saphenous veins now, although you've got to be very careful where you put the tumescence, I think you can get a very good result with microwave. So this MAESTRO study that we basically did was to assess technical success rate, anatomical success rate using the device at 2 weeks, 3 months, 6 months, and 12 months from a couple of centers in Singapore. And this was the trial flow. We basically used 4 different types of quality of life measures, an EQ5D, and we basically looked at duplex ultrasound closure as well. So this is the demographics, a mean age of about 60, high BMI, as you normally expect with a lot of these varicose veins patients. Majority were Chinese, and nearly 75% of these patients, all 100% ambulatory. More females than males as usual. In terms of comorbidities, most of these patients were ASA class 2. In terms of SEEP category, the majority we did was in SEEP 2A, who were symptomatic. In terms of procedural characteristics, we operated on basically, generally, the majority were great saphenous vein. About 13% were for bilateral incompetence. The average treatment time was about 5.5 minutes. We performed concomitant phlebectomies in about 50%, so more everyday realistic version than not doing so. And we had 100% occlusion rates based on ultrasound at 6 months, no residual bruising at 3 months. If you take it to a year, this occlusion rate, which I've not shown you here yet, is actually very near 100% as well, and no cases of numbness or nerve injury. You see where our puncture sites, nearly 65% of cases in the proximal calf or mid calf, so much lower than we normally take it down to. You see the treatment lengths are decent, nearly 45 centimeters. Pain scores are very low. You can see from day one, they drop almost immediately and go very much low down to almost zero basically by 2 weeks. In terms of returning back to normal activities, most 50%, 45% go back on the day of procedure. People don't tend to return to work if they don't have to here, unfortunately, because they get a medical certificate. So this is pretty bit artificial. About a quarter did not wear any compression stockings post-op, with even low pain scores, as you can see. And most get back to resume normal daily activity work by 10 days. In terms of clinical measures, using the different quality of life measures, so these validated ones, you can see much improvement at 2 weeks, and this is sustained through to 6 months. And I can tell you at 1 year, they're very much still staying with very few, if not any, actually re-interventions. In terms of this patient satisfaction questionnaire that we all give our patients, you can see at 6 months, 83% very extremely satisfied, and most of the symptoms have much improved. If you look at the current data, what there is, this is probably the latest paper, one of the latest papers available, looking at EMA versus a cohort of laser patients. They're from China. They used a different protocol than we did, a higher wattage. And basically, again, they showed EMA showed lower induration of ecchymosis compared to laser, shorter operative times, and lower below the knee recurrence rates. So I suspect they were puncturing it more so in the calf region. So what does the MAESTRO study add? Well, it's a multi-center prospective single-arm registry from Singapore, basically multicultural, multi-ethnic population, majority were Chinese, low attrition rate with the tight follow-up at 1 year, which I have yet to show. We use dedicated 4 quality of life questionnaire markers prospectively, used a lower power setting than anybody else has demonstrated before, with 40 watts versus 50 or 60 watts from the original Thai and Chinese data. And therefore we achieved the same kind of efficacy rates. In terms of going down low the leg, you get proper tumescence, you can actually get good tumescence around the vein and no numbness, minimal complication rates. And if you do it with phlebectomy, you can get a pretty good result. I think we're going down the line of personalized medicine. You're going to choose the right vein and use the right ablation technique. I do believe that there is a role for thermal ablation in the future. I just don't see the non-thermal, non-tumescent techniques are going to be all a game changer as yet, although I think HIFU may well actually be more of a game changer than most people think, although the cost may be prohibitive. In that, I thank you very much for listening, and I hand you back to the chair.
Thank you, Professor Tang. That was a very, very